Good morning, everyone. I am very, very pleased to welcome all of our colleagues from SCC, SFCC, and the district office. And I'm especially honored to welcome all of our students from SCC or SFCC. We are thrilled that you're here. And I am very honored to introduce to you a very distinguished friend and colleague, Dr. Francisco Velasquez. He is a very accomplished physician with a wonderful reputation throughout the country and internationally, often tapped to speak all over the world, frankly, and has a very depth of experience, not only in the medical field, but has been the CEO of PAML. He knows our colleges and in many different ways. As an employer at PAML, he hired many, many, many of our students in the healthcare fields, many students. He and his wife, Mary, have been generous donors to our foundation year after year after year, especially many packages from our fine culinary program, and he just has been very generous for many years. And so he knows us as an employer, as a donor, and the most important role that we know about him is that his two children are graduates. His daughter, Alexandra, graduated from Spokane Falls and went on to the University of Colorado, very successful. His son, Kevin, graduated last year from SCC with honors. So I am really honored and excited to present to you and want to give him all of the time because we really need to hear from him, and he's looking forward to your questions. Dr. Velasquez, we're grateful to you in all those roles you play, and importantly in the role you have now, providing us medical guidance at a time of great stress and a lot of questions that exist about the pandemic. And I have to say that very proud of the CCS team and all of our employees and students who have really done their part to kind of contain the spread of the virus within our colleges. And so with that, I want the time to go to our guest speaker and friend, Dr. Frank Velasquez. Welcome, Dr. Velasquez.
Thank you, Dr. Johnson. Good morning, everybody, and thanks for the kind words. Probably don't deserve so many kind words, but I do appreciate it. I do want to say to the audience, we've been here for about 10 years, and we are very aware of the significant role that the community college of Spokane plays in the community, not only in education, but also in generating our next generation of leaders, educators, business owners, et cetera, et cetera, et cetera. So I'm very, very happy to be here. And as Dr. Johnson mentioned, I'm a physician. Although I've been a physician, I've been an executive, I've been an educator. So I'm very happy to be able to join you today. And I have a presentation, and mainly because I'm a reform academician, so I always use slides to keep myself organized. And the way we're going to do this is we will go through this, and I have several areas that I want to discuss with you. And the way we'll do it is we'll discuss an area. I'll stop and see if there are any questions that are relevant to that topic, and then we'll move on to the next one. And then at the end, we'll open for a question and answer for however long there are questions that need to be answered. As Dr. Johnson mentioned, I'm the interim health officer for the Spokane Regional Health District. Started this position last November. And I'm very pleased to have been able to join the team and, more importantly, work with our community organizations to move the community forward. And we've made significant progress since November to today, and I look forward to making more progress. Now, educational institutions have been a interesting experiment on how to actually tackle the pandemic. And we have used internally here, as well as with our audiences, the experience that we gained from higher education, as well as K through 12 and pre-K, because the way that our educational institutions approach this particular pandemic is a good example on how you can get things done in an organized fashion and prevent transmission in a large place with lots of people interacting in many, many, many ways, including the virtual way, because that has its own set of challenges. So with that, I'm going to start my presentation. If I could get the next slide, please. Today, we're going to discuss a few areas. I'll give you a little bit of a perspective of where we are, because I think it's always important to understand where we are. We'll talk a little bit about vaccines, and I will try to cover what is relevant about vaccines in terms of how we got to where we are, what are we doing with vaccines, and the role that vaccines play in managing the pandemic, and highlight a little bit about the variants. And that's very important because the variants are into the future, the variable that will determine what we can and cannot do and when we can do it. Because as we discuss those, it will become more clear why that is. We'll talk about breakthrough cases, some of which are caused by the variants. I have a few thoughts on education, and I'm focusing on higher education because K through 12 is a little bit different. As you all know, when you're dealing with minors, it's different than as we're dealing with adults. And particularly when you have multidisciplinary, very highly complex environments like the community colleges, which is like a small town in many ways, if you think about it, because you have all the services, everything from parking to food and everything in between. So it's like a small city, and that's why we've used them, or higher education institutions as examples for the community. So with that, if we could go on to the next slide, please. Let's talk about where we are in Spokane County. And this is a graph that we use very often to put things into context. Most of you have heard about the rate per 100,000, the 2-week rolling average or rate per 100,000 population. And the reason why we use that is because it allows us to normalize over time the numbers. And the reason for that is there's a lot of variability, as you can see by the blue spikes under the orange curve. Those are the daily cases since January. And as you can tell, there's a lot of variation and variability as you look on a day-to-day. So if we were to just use daily rates, it will be extremely confusing because you could be going from 60 cases to 200 cases overnight. And the rate tells us more or less where we are. Now, if you recall, for the governor's roadmap to recovery, phase 2 and 3, particularly phase 3, we were using the 200 per 100,000 rate. And as you can tell, we've been above that a little bit, particularly over the last 2 or 3 weeks. And that is a result of many things. One of them is we did have a little bit of a backlog of cases that the Department of Health released in the last week or two. So that artificially inflated our numbers somewhat. But we also know that as we started to get back into the economy, there's a little bit more transmission that occurs, particularly in the younger populations, and we're going to see that in a few minutes. So we did expect to see those numbers rise a little bit between March and April, and then into May. And now we should begin to plateau and eventually go down as the next few weeks and the next few months. If we could go to the next slide, please. I wanted to give you a little bit of a perspective of what those numbers look like if you're looking at it from a demographic perspective. And the reason why I say that is because the disease initially, the vast majority of the impact was in those 60 and older, and those tended to carry the bulk of disease. And as you can tell by the numbers we have now, particularly the 80 and 90 and the over 70, they're a very small percentage of the cases that we see. And the rationale for that is because we have protected our elders. We've also immunized 3/4 of them and prevented disease, because in the elderly and those with comorbidities, the disease carries a lot more morbidity and also a higher level of mortality. So it was important to protect that segment of the population. So what we saw, particularly in the spring, and specifically when we had the convergence of Easter, spring break, and March Madness, which doesn't happen very often, but happened this year, we saw an increase in the age group between 20 and 39, and that has been sustained. And if you look at these numbers for the last couple of weeks, you will see this 2029 has been between 20 and 25%, probably for about 8 or 10 weeks or so. So the vast majority of the new reported either positives, and what I mean by that is they may not have disease, but they're still positive. So they do have virus and can transmit. And those that are new cases is in the younger populations. So if you go between 10 and 50, that's the bulk of the cases that we have. And the reason why we include the 10 to 19 is because as we started to increase the number of activities in schools, K through 12, particularly athletics and other activities like that, it was expected that we will see some transmission around those, not necessarily in those, but around those. And we have seen a little bit of that. Next one, please. I'm sharing with you what were the metrics being used for the roadmap to recovery by the governor and the Department of Health, and that was cases and rates, hospitalizations, and testing and positivity. We use the testing and positivity for a while, but we're not using it currently. And the reason for that is because at this point in the pandemic, the positivity rate waxes and wanes depending on who is getting testing, as we only test for cause. But what's important to see here, and if you direct your attention to the hospitalization and 7-day rate per 100,000, you will see that has declined. And that is important because the main goal, one of the two main goals behind any immunization program, and specifically the COVID vaccine, is to reduce the type of illness that will land you in the hospital and also to reduce mortality. And we have seen both of those come down significantly. So right now, the Spokane County is close to 300 per 100,000, which is a little bit high. We do expect that to come down when we normalize some of the backlog from the Department of Health. But the goal is to see that rate mimic what we have seen in hospitalizations and plateau and start to go down, which will take a little bit longer just because of where we are in terms of transmission in the community. Next one, please. So I'm going to stop here and see if there are any specific questions about where are we at in Spokane County. And to give you a perspective, when I joined the agency, our rate per 100,000 was 904.5 per 100,000, which is very significant compared to where we are today. So if there are no questions, I will move on to talk a little bit about vaccines. And this is a topic that I know everybody's interested in. We've got a lot of questions, and I do know, I did see something come up in the Q&A.
We did get one question. Why are we just now getting test results from several months ago?
Yeah, so there was a systems issue in the Department of Health that was discovered and addressed. And basically what it boiled down to, and that's a great question, we had some reports that went from all the way from December the 19th through about May. For example, in the positivity, meaning lab results, there were about 22,000 that were not entered into the system at the appropriate time for a variety of system issues. So those have been not only updated as of now, and that's why we saw some spikes in our information. And you know, if you run information systems, and many of us have been responsible for information systems, occasionally you see these backlogs because of either data entry or lack of transmission, or because the data has not been submitted in a timely fashion to the state. So there's multiple reasons. The good news is it was identified, addressed, and we have updated our information as much as possible. And if you look at our rate, our rates have been over 200 for a little bit of time. And that has to do more with transmission in the community as opposed to with data. And as I mentioned, there were a number of reasons why we saw those increases. I do see another question: how do we fight false claims on the internet and in social media? Well, I think the way that I typically address any question is I provide the facts to the best of my ability, and then ask people to make their own decision as to what does that mean. And when we talk about vaccines specifically, I do want to emphasize my philosophy and my professional opinion is immunization is a personal decision that an individual must make, hopefully with the assistance of their provider, because there are reasons why we have access to primary care providers. And my role is to provide as much information as I can and help people make the decision that is best for them. Now, as a public health officer, of course, I am supportive of immunization and getting as many people immunized as we can. But I have spent a lot of time over the last 8 weeks or longer addressing questions that people have, and I think every question is good. And the fact that people are asking questions means they're interested, they want to know. I've had many people ask me questions about why should I get the vaccine, and I try to explain that. So I think questions are very important, and one of the reasons why I do these presentations is to promote the conversation, because a two-way conversation is the best way to address any information that is needed for whatever the reason or the purpose is. So if we go into the next slide. So as you all know, there are 3 vaccines that are currently available in the market in the US. And the reason why I say that is because there are probably a couple hundred worldwide, and there are probably about 12 that are the most common in not only in the US, but also in, if you take Asia, Europe, Middle East, there are a number of other vaccines that are available, like the AstraZeneca that you hear about and the Novavax, et cetera, et cetera. But those have not made it through the process in the US. And the reason why I point that out is because the process that the Food and Drug Administration, the FDA, has for vaccines and therapeutics, not just for vaccines, but for every therapeutic, is a very stringent process that requires a fair amount of documentation as well as clinical trials data. And these vaccines, all 3, have gone through the same process that all therapeutics have. One of the questions that I get very often is, how did we get to these vaccines so quickly when it usually takes so long? And there are a couple of reasons for that. Reason number 1 is, at least in my professional career, I do not recall any other time in practice where so many resources were made available for a singular purpose. And what I mean by that, not only this country, but the world came together in providing resources to move immunization and vaccine trials forward in a way that is totally unprecedented. And of course, if you can multiply your efforts with the appropriate resources, you can achieve the goals a lot faster. And anyone that has run a business know that if you can scale up, you can get things accomplished sooner. So that's reason number 1. Reason number 2, we have seen an unprecedented level of collaboration between companies. Instead of competing, they have partnered. For example, Pfizer BioNTech, those are 2 different companies. Pfizer is a really big company, one of the world's largest, and BioNTech is a smaller company, but is a really advanced biotech company that partnered with a giant in a way that allowed them to get to market this vaccine quickly. Moderna was also a partnership with the National Institute of Health, and Johnson & Johnson leveraged one of their subsidiaries, Janssen. That's why you hear the Johnson & Johnson Janssen vaccine, to move this forward. So the level of collaboration was unprecedented. And then lastly, the technology that was used particularly for the Pfizer and Moderna, known as the messenger RNA technology, or mRNA, has been around since the 70s and has been used before for other vaccines, particularly in the 90s. It was used for vaccines for the flu, rabies, cytomegalovirus, and Zika virus. So we did have technology that was already readily available that allowed us to move a lot faster because we did not have to develop a new technology. The Johnson & Johnson vaccine uses what is called a vector, which is also a technology that has been available for a while, where you take a virus that is not harmful and load it up with some signals to produce the antigens that tell your body that you should make antibodies against this particular antigen. So these are the 3 vaccines that are in the market, and I want to talk about that for a second. Next one, please. So as I mentioned, Pfizer and BioNTech are both messenger RNA vaccines, and Johnson & Johnson is a viral vector, uses adenovirus, and adenoviruses cause a mild case of common cold that have been neutralized in the laboratory, so they cannot give you a cold, have been neutralized and used as a vehicle. So let me talk about messenger RNA for a second, if I can, because I know that was one of the questions. So if you go back to your genetics classes, you know that there's DNA, there's RNA, and one of the main roles of the messenger RNA is to provide the signals to your body about, which proteins to make, for example. So the messenger RNA vaccine technology is based on creating in the laboratory messenger RNA based on the genetic sequence of the virus. And we've had the sequence of the virus for months. We had it since very early on in the pandemic. You take that sequence and it tells you what are the combination of nucleotides, et cetera, that you need to manufacture this messenger RNA. And the messenger RNA that was manufactured in the laboratory was specific to generate the production of what is called the spike proteins. If you recall, these viruses are called coronaviruses, and they're called coronaviruses because if you look at an electron micrograph of the virus, it looks like it has spikes on its surface, and the spikes on the surface look like a crown, hence the name corona, which means crown in Latin and also in Castilian if you are Spanish, and like I was born in Madrid, and so Castellano. So coronavirus means it has a crown-like appearance. And those spike proteins that give it the crown-like appearance are the glycoproteins that attach to the cell receptors and provide the signal to the human cell receptors to replicate the virus. So making antibodies to those is very important because it's one of the most important targets of the virus. So what we did in the laboratory was create the messenger RNA that will generate that response. You inoculate that in individuals, it goes into the cytoplasm of your cells. And I want to be very specific that it goes into the cytoplasm of the cells, never. Actually, that's the recording says cells, like you're selling something, not cells, cells. But anyway, it goes into the cytoplasm of your cells. It never enters the nucleus, so it has no potential of interacting with your DNA at all. And it provides the various structures in the cytoplasm of the cell, the signal to produce this glycoprotein that gets released into your bloodstream. And that's the signal that generates to your body the need to make antibodies against this foreign protein. And that is how it works. The messenger RNA itself is very labile, doesn't last very long, never interacts with the nucleus of the cell, so it cannot change your DNA. And because there's no virus, it cannot give you the disease. And I wanted to talk about that a little bit because I know there were questions about that. Now, the way the Pfizer and the Moderna vaccine work is a 2-dose, is a booster. One is about 3 weeks after, the other one's about 4 weeks after. Johnson & Johnson is the only one of the vaccines that is a single dose. As you can tell, the peak effectiveness is typically, we say, about 14 days or 2 weeks after either one of the 2 doses and about 14, 28 days after the single dose. But they all work extremely well. If we can go on to the next slide, please. And I see a number of questions I'm going to add, probably address at the end. Let me go and finish this, and then we'll talk about those. So when we talk about vaccines and clinical trials, and I want to emphasize that there's 4 phases to clinical trials that typically therapeutics go through. There is one exception to that, which is when we apply the emergency use authorization. And the emergency use authorization is a process that allows us to release something after the 3rd phase. So you have gone through all the efficacy and safety phases of it. And typically the last phase, phase 4, is where you accumulate hundreds of thousands of data points as opposed to tens of thousands. And all these vaccines went through clinical trials with 40, 50,000 patients and people in a variety of environments. And when you look at clinical trials, we talk about efficacy and we talk about effectiveness. And efficacy means how good is the vaccine at preventing disease, morbidity and mortality in those that are part of the clinical trial. And effectiveness is once we release it into the real world, what does it look like? And bottom line with these vaccines, they're all very good. And if you recall, I mentioned earlier, 2 of the main goals of a vaccine like this is to A, prevent severe disease, and B, prevent mortality. And these are all over 90%, 99.5% effective in preventing severe disease and transmission, and they're about 100% in preventing mortality. Next one, please. When you get the vaccine, you get something called a reactogenicity, which is normal, meaning your body is reacting to the signal to activate the immune system, and that's why you get fatigue, fever, sometimes headaches, soreness at the injection site. There may be some mild reactions. We haven't seen very many allergic reactions, which is good. And you feel like almost like you're fighting something, although you're catching something. Typically lasts 1 to 3 days. Most cases are extremely mild. There's a couple of cases where people feel a little bit sicker, but for the most part, most of the side effects we've seen have been minimal. Next one, please. So where we are right now is we're immunizing those 12 and older as of a couple of weeks ago, which is about 85% of the population. And I can tell you population-wide, we are about close to 50% of the total population that is eligible has received at least 1 dose. And the state is about 60, 61%. The goal is to be 70% by June the 30th. I do believe the state will get to the 70% before we will. Not uncommon in the eastern part of the state, in all immunizations tends to be a little bit behind the western part of the state, and that's a historical fact. But we are making progress every single day, and I am confident we'll get to that 70% also. Next one, please. So if you have any questions about immunization, we put together tons of information in our website. You just have to go to the srhd.org, click on COVID-19 vaccination, and then you will see all of those. I've also recorded about 4 or 5 Facebook Lives. I do those every Wednesday that are specific to vaccines, if you want to see those. And we've had a couple of editorials in the paper that have come up. So I'm going to look at the questions, see if I can answer. Okay, so there are a lot of questions. Let me try to summarize as best I can. So the first one is the EUA. That is correct. The EUA is a pre-approval process. I do know that Pfizer has shared with the FDA, because that's public information, that they will seek approval, full approval through all 4 phases sometime in the summer. And then they will seek emergency use authorization for people younger than 12 in the fall, and then those that are 6 months to 2 years of age or a little bit older by the end of the year. So this will continue moving. And the fact that they were released under emergency use authorization doesn't really mean that they can go through all of the processes that they have to go through. Then the second question has to do with boosters. Most vaccines, typically, you do get a booster shot at some point. And there's a lot of research being done on boosters. We don't know how often, if any, we'll have to do that, but I would expect that when the disease becomes endemic, it will be similar to the flu. We will probably need to get a shot every so often. Question about we're about 50%. What is the estimate from where are we gonna get to 70% or so? Well, I'm hopeful that if we don't get, oh, I see. If we don't get through that by June the 30th, we get there soon thereafter. I've been asked by the press, do I have a goal for the community? And I said, my goal is 70% also. And the reason for the 70% is a number significant enough that will give us some confidence about potential protection in the community. If you recall, there are about 8% of the population that have had disease, so they may have some antibodies. And between that and immunization, we'll be pushing 80%. In terms of rural sites, yes, we do have a number of deployable clinics going to rural sites. We're also working with the fire department, both county and city. We're using fire stations in many of the rural communities, as well as we have deployable clinics. We have been using schools, community centers, and other organizations in rural areas, as well as in many other areas in the community. So with that, let me look. I think I covered most of them. And the question was about adverse events. Adverse events are reported, but I do know that some folks, if they did not feel particularly sick or they felt sick but did not associated with the vaccine, may not have reported it. So again, the information is only as good as they're reporting. And the good news is we do have a lot of reporting compared to the number of vaccines. But we do know that perhaps not everybody is reporting what they see. So I think with that, we maybe.
Velasquez, I'm just going to point out, we had a couple people ask whether or not someone who has had COVID should still get vaccinated.
Yeah, and that's a very good question. The answer is yes, and there's several reasons for that. If you look at the literature, it's conflicting in terms of how long do the antibodies remain. And also the antibodies that are specific to, for example, the spike protein, which is one of the key targets behind for the virus. We do know that the various variants through mutation have been good at kind of masking the spike protein. They're kind of blunting the normal immune response of the human body against the virus. We also know that in analyzing lymph nodes, we don't see some of the same high activity germinal centers in the lymph nodes that we see in other diseases that are necessary to generate the long-term cells that will have the memory of the virus and react to it accordingly. And again, I say it's conflicting because there's new research coming out every day. And if you think about it, this virus hasn't been around long enough for us to really know everything about it. And then lastly, there have been a number of reports in the literature about a T cell, and you know that T cells are also part of the response. They carry the memory cells. The response of the T cells is not as active as we have seen in other viruses. Now, we also know that the vaccines are really good at generating a polyclonal response with a very high level of neutralizing antibodies against the spike protein, which is what you have. And in terms of real life experience, we have seen the morbidity, the transmission, morbidity, and mortality in those that we immunize early, such as our senior citizens, go down dramatically. And if you think about countries like Israel, where they had a massive immunization campaign, and they're probably ahead of the world in that, there's been a dramatic increase in disease transmission, morbidity, and mortality, all because of immunization. At the end of the day, the best answer for did I have disease? Should I get the vaccine? The answer is yes. And I just want to emphasize with that that you can get the vaccine provided if you had disease and you're not symptomatic and it's been over 2 weeks and you meet the criteria for being released from isolation, and you can go to the CDC website to look those, which basically means you don't have any symptoms, you can get the vaccine. That's a very good question.
And then the other one I saw was from President Brockbank, Kevin Brockbank, asking about the possibility of a mandatory vaccine requirement for higher education employees and students, and your opinion on that?
Well, I do know that every institution, every business, every organization is looking at the best way to manage that. I usually try to motivate rather than mandate, but if it does become a public health issue, I'm sure that the Department of Health and others will provide the recommendations accordingly. Businesses right now are having a difficult time making that decision. That's why many are still emphasizing the use of facial coverings and social distancing, regardless of immunization status for their employees, because you can't tell who is and who isn't immunized. I do know some institutions are requiring the vaccine. Some institutions are requiring the vaccine with some caveats, and some institutions are not requiring the vaccines or have not made a decision. At the end of the day, I think the goal is let's immunize as many people as we can. If there are questions about it, let's try to answer the question. This morning, I was addressing a group that has what I will call somewhat of a historical lack of confidence or confidence issue with vaccines. And the point is, we'll have questions. Let's get the answers. Let's get the information. At the rate we're going, it should, if we continue this rate, we should get the 70% probably before June the 30th. And if so, then the question is, how far and can we go in the subsequent weeks and months, particularly as we look at the fall and we look at the potential for having vaccine for those that are younger than 12, which will include children. And the reason for children do have lower transmission rates. They don't have the same disease burden, but we've had about 4 million cases that are positive and or are sick in children in the country, and they have been between 1.2 and 2% of the hospitalizations. So even if they probability for disease and morbidity and mortality, and we've had some mortality in younger people, is very, very low, they can still transmit to those that are higher risk. So they're part of the transmission chain. Good question. So with that, if we could go on to the next one. And at the end, I can always come back to other questions about vaccines. So one of the areas that I told you is a variable and will determine a lot is the variants. Viruses mutate like all organisms, and I use the word organism loosely because the viruses technically are not an organism since they're not really alive, although they're part of the natural balance of things. And they mutate with a certain frequency. The SARS-CoV-2 mutates every 11 to 15 days, so about twice a month. That's probably not as fast as the flu, but it's faster than some and slower than some. And the mutations do one of three things: either make very little change to the virus, make changes that are detrimental for the virus, and the virus kind of like fades away. That's why some of the variants don't last very long. Or make changes that make the virus more effective and efficient at transmission, and that's where some of these variants of concern come in. And when you have similar genetic mutations in a lineage, that's what we call a variant. And this, by now, there are about 13,000 documented mutations, and there are probably between 2,000 and 4,000 variants, depending on what system you use to call a variant. And many of these variants are inconsequential, at least from a disease transmission perspective. They don't seem to have any biological advantage. Next one, please. So in the US, we use the system of classification, variants of interest, which are those that we're tracking, but we don't have scientific data that says that they're more effective, more efficient, or can blunt the immune response. Variants of concern, which are the ones that we do have scientific data that they're better at transmitting, they can cause more morbidity, and they can blunt the immune response. And then the last category, variants of high concern, which we don't have any at this point in time, are those for which the countermeasures such as vaccines do not work very well. The good news is we don't have any of those at this point in time. The reason for that third classification is because we all know, based on our knowledge of viruses, that eventually that may be a possibility. Next one, please. So these are the variants that are circulating in the country that are variants of interest, variants of concern. And this make the majority of the variants that we know that are commonly being tracked in the US. And as you can tell, and I'll call your attention to the B16171, 2, and 3. We just added those 2 weeks ago to the variants of interest. These are the variants that caused the surges in India that we read about and saw about over the last few weeks. The B117, also known as the UK variant, is a predominant variant. And we had predicted back in February that by May or June, B117 will be the most common variant in the US. And I think we're on track to see that happen. The P1 variant is known as the Brazilian variant, and that is increasing in frequency in the country and increasing in frequency in Spokane County. I'll show you that in a moment. And the reason why we track this is because the variants of concern, as I mentioned, have mutations that give them some biological advantage in terms of transmission and infectiousness. Next one, please. So this is what we have in the state of Washington, which kind of mimics the country with one difference. We do have the number one variant, the B117, but we also have the B1429 and 1427, which are more common in the western states. They were identified in California a few months ago and became fairly common in the state of Washington, particularly the B1429, which is a variant of interest. Next one, please. If we break that into the lineages, that gives you a very clear perspective of how the B117 has been increasing over time over the last several weeks, because the further on the left is March 14th, which is not that far away. And the furthest to the right is first week in May, and we do this in 2-3 week blocks. But we are on track for the B117 to dominate over the next few months. Next one, please. In Spokane County, we have a little bit of an interesting situation, which is where the P1 is almost as frequent as the B117. We don't have a reason for that. The first case that was sequenced, and I say the first case because we don't know the index case. It may have not been reported, may not have been symptomatic, may not have been sequenced. The first case had no history of travel, international, local, or otherwise, so it's really hard to know. But once a variant is in the community, because they're more efficient at transmission, you see them more often. So Spokane is a little bit different than the rest of the state, where we have more P1 than other parts of the state. Next one, please. I'm going to stop here and just highlight the fact that some of these variants have been related to what we call breakthrough cases, but I'm going to talk about the breakthrough cases in a moment. And those variants have caused some of the breakthrough cases, meaning those that are infected after immunization. And we have seen a couple of cases of reinfection, particularly in some of our seniors. I'm going to stop here and see if there are any. Let me check the questions on that, on what we just discussed. Let's see, summer vacation. Vaccination does not prevent an individual contracting COVID. So no vaccine is perfect, but to give you some idea, these vaccines are about 94, 95%, depending on which one you're talking about, effective in preventing disease. The typical flu vaccine is 40 to 60%. So as it pertains to effectiveness in the real world, these are probably some of the highest effectiveness or most highly effective vaccines we have seen. But yes, no vaccine is 100%. So some people will get disease even if they're immunized. So I'm going to go on to the breakthrough cases for a little bit, then we'll get back to the questions. Next one, please. So in Spokane County, we have about 93 that have been confirmed, 9 that are probable. The state has over 1,013 that we're investigating. And the reason why I say that is because to be called a breakthrough case, you have to clearly document that it has been after full immunization, which is 2 weeks after any of the 2 shots or 1 shot. And then we typically do all of the contact tracing as well as the lineage to see what type of, if there's a variant involved. Some of these breakthrough cases have been sick enough to be in the hospital. There have been 2 mortalities, and both have been associated with very elderly people that had a number of other comorbidities. And many of our cases are associated with some of the long-term care facilities, which is something you will expect. And the reason for that is you will expect those that are at higher risk for infection, transmission, and disease, even if they're immunized, to have the highest frequency of breakthrough cases. And we see that with the flu, we see that with all vaccines. And if you have kids in school, for example, you get the call from the nurse that, X child has disease. Now we do contact tracing all the other ones, even though they were immunized. So breakthrough cases is not a new thing, but we're tracking these very, very, very carefully as this is a new virus. We want to really not only learn, but prevent as many as possible. Next one, please. So as I mentioned, we sequence the breakthrough cases, try to determine if it's one of the variants of concern. And we have not completed some of the cases from April and some of the cases from May. And the reason for that is it takes a long time to get all of the information, get all the sequencing done, et cetera, et cetera. But the interesting thing is that we saw 3 of these cases in April, as I mentioned, be of the P1, which in and of itself is an interesting fact. As I mentioned, we do have more P1 in Spokane County than other parts of the state. P1 was identified originally in Brazil, and it was very specifically related to cases of reinfection. Although the 4 case index cases, or at least initial cases, were identified in a flight from Brazil to Tokyo. And that's why it was identified in Japan, but was traced back to the Amazonian region of Brazil. Next one, please. So I'm going to stop here. Let me look at the chat and see what we have in variant. Okay, very good question about what is the vaccine future with all these variants. Well, we have a lot of research that is ongoing, and we do know a couple of things. Fact number 1 is we do know that the current vaccines do have protective effect against the most common variants, including the B117. And we have seen that from studies performed in people that were immunized early in the process, such as healthcare workers and first responders and others. So we do know that. Second, we do have the in vitro experiments that have proven that ability. And lastly, all of the companies, particularly the 3 that I mentioned that are active in the US with their products right now, do have a number of studies on the variants in the potential of a booster at some point in time that will be more specific for the variants of concern. But we do know that it works. We do know that it works with the flu, and we do see it working with this particular one too. So if we go on to the next slide, please. So I mentioned a little bit of where we are in the community. The governor said that we could reopen by June 30th. That means that we may see more activity if we get there. And the reason why I bring that up is that despite that, I think we've learned a lot about sanitation. We've learned a lot about ventilation in buildings, particularly in education and businesses. We've learned a lot about good respiratory hygiene. And these are things that are important, whether we have COVID or any other disease. If you look at the flu season, has been more or less a non-event in terms of cases, although we did have 1 pediatric mortality with the flu, which is extremely unfortunate. Every mortality is unfortunate and painful. But in previous years, we've had about 200. So obviously, some of the things that we're doing right now are good practices that we should try to continue. As you all know, the CDC and the Department of Health have realigned somewhat the social distancing as well as the masking for fully vaccinated people. And we're going through all of that as are all of our businesses and higher education institutions. Next one, please. So I think as we anticipate in education, there's still a direction for physical distancing and mask usage. We don't know whether that will change by the fall or not, because there are a lot of conversations that are happening around us that may dictate a different course of action. But as we've shared with our K through 12 partners, right now, facial coverings and some distancing is still going to be there in the fall when we get back to school in person. Whether that is different or not, we will keep track of it. There may be some realignment in the summer, but at the end of the day, wherever we start the academic year, I guess the message is not where we're going to end, because things will progress and things will be revised and realigned as we learn more, as we're doing every day. And athletics, which is a very specific activity, good news, we have a fair amount of work being done by the various conferences. Like we did spend a lot of time working with the NCAA, particularly when the Zags were playing because of the travel, et cetera, et cetera, et cetera. So there's a lot of work that is being done through the conferences for athletics in terms of vaccination, et cetera. And cafeterias, we do know that when the masks come down, and we saw that in schools, when the masks come down because of break in the lounge or because of cafeterias, if we're not careful with some of the distancing and some of our practices, we do see some transmission. So one of the things that we have suggested to our friends in the K through 12 is, friendly pods. Like we go to lunch with, some of our people that we tend to spend time with. And that's a good way to prevent a transmission, as you have this pod of people, this cohort of people that spend some time together inside and outside of the classroom. But these are some of the things that schools are going to have to think about. Next one, please. I think some of the challenges that the organizations are going to have to face is, do we ask people, or do we assume that people are doing the right thing? And what that means is where they should wear a mask, because education is an exception to some of the unmasking rules that we have seen from the CDC. Should we ask people? Should we assume that they're using masks appropriately in the appropriate scenarios? Should we assume that people are vaccinated? And there was a question about vaccine passports. And I think the issue with documentation for immunization, that's a decision that institutions and businesses need to make. And one of the questions that I get asked, is that a HIPAA violation? And the answer is no. Because HIPAA covers healthcare and its associates, and education is not in that environment unless you're talking about medically protected information because of a clinical condition. What would be a HIPAA violation is if you told me, well, I cannot get immunized, and I said, well, can you prove to me what your disease is that you can get immunized? Well, that enters into your protected medical information and starts to border on a violation. So next item I want to talk about is a little bit of testing. I know the community colleges have been offering access to testing, and I will encourage us to continue doing that. I do also know that there's a lot of deployable testing. We from the Spokane Regional Health District have deployed about 37,000 rapid antigen tests, and we've leveraged those in pretty much all scenarios that we can, from education to retail, and has been very helpful in preventing outbreaks as well as in facilitating activities. Example, one of our high schools used the antigen testing to determine which students could attend a kind of like a socially distanced and very safe prom. And there were 2 students that tested positive, so they were not allowed to participate. So we will have also some concerns from people that may not feel totally comfortable in the in-person environment. I think is the best way to address that is through information, communication, and conversation. And the documentation for fully vaccinated people, we, for example, in our building, since we have a hybrid, we do have healthcare components of the building. So those will have to remain with the stricter guidelines. We have some, what I would call back office type scenarios that are a little bit different and are more like a business as opposed to an agency. So for those, our employees are voluntarily sharing with human resources their immunization status. We're not telling anybody they have to, they're voluntarily doing that. And many of us, I just took a picture of my card and have it on my phone in case I need it. I can tell you I still wear my mask, particularly if I'm going to be surrounded by people or I'm going to be in a crowded place, because I don't know who's immunized and who isn't. And I don't know if there's any symptomatic case near me. And I just do that for not only for my own protection, but because I'm also trying to protect my family, my colleagues, my friends, and all, and making sure that we as a community can continue to move forward. Next one, please. So some of the things that I will suggest we think about, and we've been having these conversations with education. I do believe we're going to see a lot more in-person instruction come the fall season. We'll have to start transitioning a little bit on the 6 feet of separation to something that may be no distancing restrictions a few months from now. Vaccines, I know that some schools are thinking about requirements, some schools are not thinking about requirement. If we don't know immunization status, I do think that some facial covering and some other precautions are still good to have. And I do know that testing has been made available to students, and I will encourage that practice to continue because it is good in identifying those that could be asymptomatic or could have been a close contact and they didn't know they were a close contact. So it's something that will encourage us to use. Next one, please. So with that, I'm going to stop and see if there are any other questions that we haven't answered. And I know it took me more than the 25 minutes that I had allocated, but I tried to answer the questions real time as I saw them in the chat, and that always adds a little bit more time. Are there any other questions that I may be able to answer? If we want to put back the cameras or the people, I'd be happy to answer any other questions that we have. Oh, here we are. I see faces again. Let me see in the chat. Will we have access to rapid testing for students who arrive to, oh, I see Amy raising her hand. Yes.
I can address that one. Right now, we are currently having all students and employees who are on site complete a daily attestation of their health, and that includes whether or not they've been exposed to someone who has COVID or they're exhibiting symptoms, and we're asking people not to be at CCS if that is the case. Since things have changed a little bit, now that we're having more folks become vaccinated, we actually have a more detailed checklist on our internet site that talks about your particular situation, if you've been vaccinated, when you've been exposed to someone. So I'd like to use this as an opportunity to promote the resources that we have on the CCS internet site. There's also a place where you can find where to get a vaccine closest to you, and that also includes our folks who work and go to school at the rural sites. There are a number of resources, links to the Spokane Regional Health District Centers for Disease Control. So if you haven't looked at that site on the internet, you can find it if you look at the purple banner at the top of all of our web pages.
Thank you. That's a very good answer. And I want to emphasize something you said. Both the community colleges as well as Spokane Regional Health District have a lot of information available. Go to a website, click on it. You'll find all kinds of stuff. We even have a blog and some suggestions on how to celebrate Memorial Day safely. We did that for St. Patrick's Day, we did that for Easter. So there's always a lot of information. There's a couple questions here that I think are important. One is, should we carry our vaccination cards? Well, I personally just have a picture of mine in my phone because it is the prerogative of businesses to ask that if they so choose, if that's their policy. Now, you don't have to enter a business if you feel that that's not an appropriate question, but they do have that right to ask that question. So I just have a picture of mine, and I don't mind saying, yeah, sure, I have it. The cards, you don't want to lose it, but there is a site where you can go and get your immunization status if you do lose it. The other thing I see, will the COVID vaccine likely become an annual vaccine? Hard to tell, but based on what we see, more than likely it will, as it becomes endemic, the answer will probably be yes. And I think I'm going to stop here because we're at the hour and I'm being respectful of people's time. I do appreciate the opportunity. I don't know if there are any last questions you would like me to address, but I'm going to stop here and see what else we need to do.
Well, Dr. Velasquez, I have to just say on behalf of all of our employees and our students, we're so grateful to you for the time you've made. We know you are everywhere, all over the county, answering questions, making yourself available. And we appreciate your expertise and your understanding of the different situations and questions that students and employees rightfully have. So we thank you very much. This has been very informative, and I hope it has helped provide information to students and colleagues within CCS that had questions. So I just am very happy for the time you've spent with us. And we also very much appreciate that you're out and about everywhere. And I know that all of our colleagues within the higher ed community have tapped you, just constantly. And we're very, very grateful for that. And on a personal note, we just appreciate your continued support of our colleges and our students and, your generosity with our foundation. So we're just grateful for you having spent your morning with us. And thank you also to all of our colleagues, CCS colleagues, and all the students who participated today. Very important to stay informed. Hope you learned something. And I also want to thank Amy and Kathy and Carolyn and Jonathan for the work they've done in getting this together and facilitating the conversation. So thank you, Dr. Velasquez. Have a great rest of the day, and we hope you will have a safe and relaxing Memorial weekend. So thank you, everyone, for joining, and appreciate you very much, and have a great weekend, everyone.